Okay, great. So we've hit the magic number 50. So let's get started. So good evening or good morning or good afternoon, depending on where you're logging in from. Thank you all for taking time out to attend this session. For most of us, it's a Friday evening, so we appreciate it even more. And we try to keep this as interesting and engaging as we can. This webinar on women's groups and health in India is being hosted by the Evidence Consortium on Women's Groups and the University College London. My name is Ashwin, Iyer. I work in the India office of the Melinda Gates Foundation, and I'll be moderating the session for today. We have a fairly simple agenda lined up. We have the first 15 to 20 minutes for a presentation by Dr. Sapna Desai and Dr. Audrey Prost on the program implications of a recent systematic review on women's groups in India that they'd undertaken. Dr. Sapna Desai is an associate with the Population Council in New Delhi and is a co-lead of the Evidence Consortium on Women's Groups. Her work focuses on community-based interventions, sexual and reproductive health and rights, and health systems research. And she previously spent over a decade working with SEWA, where she led the scale-up of SEWA's community health programs in 6 states of India. Dr. Audrey Prost is a social anthropologist with training in epidemiology and is the director of the Center for Health of Women, Children, and Adolescents at the University College London. Her research focuses on participatory community interventions to improve women's, children's, and adolescents' health. And she's been associated extensively with the Ek program and has conducted evaluations of community-based interventions to improve maternal and newborn health, children's growth, and adolescent health in Jharkhand and Orissa. Post the 15 to 20-minute presentation, we'll then maybe spend the next half hour with on a discussion with our panelists. We're really excited to have with us today Dr. Rajani, who is the Executive Director of NHSRC, which provides technical support to the Government of India's National Health Mission. Her work focuses on linking community processes with health systems and supporting the implementation of comprehensive primary healthcare. And her expertise includes design and evaluation of large-scale health programs, implementation research, and scaling up. We're also really excited to have with us Dr. Vijayendra, a lead economist in the Development Research Group of the World Bank. He leads the Social Observatory, an interdisciplinary effort to improve the conversation between citizens and governments. He integrates his training in economics with theories and methods from anthropology, sociology, and political science to study the social, cultural, and political context of extreme poverty in developing countries. We're also fortunate to have with us Dr. Purnima Menon, a senior research fellow at IFPRI New Delhi. She is the theme leader for the South Asia nutrition programs in IFPRI's Poverty, Health, and Nutrition Division. She directs the Poshan Initiative, which is an initiative that supports the use of evidence for nutrition in India and conducts implementation research on scaling up maternal and child nutrition interventions, as well as evaluating large-scale behavior change communications programs in nutrition and health. So post the half-hour discussion with our panelists, we'll open the floor up for the last 30 minutes of the conversation for any questions that the attendees might have for what's been presented or for what our panelists have discussed. And we'll try to leave some time at the end for a short wrap-up as well. Before handing it off to Sapna and Audrey, I just wanted to mention a couple of house rules. We are recording this session, and we'll send out a link of this recording to everyone who's registered. So you don't have to take down any running notes during the conversation. Also, if you have any questions, comments, or clarifications during the presentation or later, I'd request you to use the Q&A function that you'll see in the Zoom action bar next to the chat and participants buttons. It will also be great if you could preface your statements by saying it's a question, a clarification, or a comment, so that we could either choose to respond to it in the chat itself or respond to it verbally during our discussion. So yeah, that's about the spiel from my end, and hand it over to Sapna and Audrey to take us through the presentation. Thanks.
Thank you, Ashwin. Just going to share screen.
Yeah, we can see it. I think you can just go to the presentation mode. Yeah, perfect.
So thank you so much, Ashwin, and thank you to all of you for joining us on this Friday evening or morning. As we all know, women's groups already operate at quite a wide scale in India, working on health, most prominently recently through the National Health Mission, supporting ASHAs to engage women in participatory learning and action through groups, and also the addition of health and nutrition and WASH to the National Rural Livelihoods Mission. And of course, a long history of community-based groups engaging women's groups on health. So despite this extraordinary scale and investment we've seen in the country working towards health, there's been no synthesis of evidence. And that was the primary motivation for this review. And with this review, we aim to achieve two objectives. The first is, what impacts have women's groups had on women's and children's health? So essentially, what has worked? And also, we sought to understand why, through identifying enablers and barriers related to three areas: to context, to the design of interventions, as well as implementation processes, and characteristics of the outcomes that the interventions aim to achieve. So I'm going to turn to my colleague and co-author, Audrey Prost, to walk us through the findings on impacts, and then I'll come back to you around enablers and barriers.
Thanks so much, Sapna, and hello everyone. Thank you for joining us. And so we did a systematic review of both quantitative and qualitative studies published in the peer-reviewed or the grey literature between early 2000 and the end of 2019. We included studies that described health-related outcomes for women and children in India. And these outcomes could be knowledge, behaviors, but also hard health outcomes, things like mortality, for example. We searched 10 databases that span the medical and social sciences. We looked at bibliographies and contacted experts for additional references. 6 of us extracted the data, and 2 of us, that's Sapna and I, did the quality appraisal and the final synthesis of studies. To map the social and behavior change approaches used in different interventions, we used a taxonomy published in 2015 by Koch and colleagues, which included categories relevant to group interventions, particularly to collective action. But as we started to review the interventions, we also felt the need for a simpler, more intuitive taxonomy of group interventions. And so we outlined a set of ideal types of group interventions, which I'll describe to you in a short while, and Sapna will then build on. So we found 99 studies on groups and women and children's health from India, including 44 trials, 19 of which were randomized, 25 not, and 55 non-experimental studies, the breakdown of which you can see here. What quality is the evidence on groups? Well, 12 of the 17 randomized control trials had some concerns or were at high risk of bias, and just over half of the quasi-experimental trials were at serious or critical risk of bias, and we can talk about why if you're interested in the discussion. Overall, we found more studies were conducted in UP, Bihar, Jharkhand, Orissa, and Karnataka. And the map on the right looks specifically at experimental studies and suggests that more of these Bihar and Orissa. So the largest group of studies that we found focused on reproductive maternal newborn health. Though a surprisingly small number, only 2, looked at family planning. We found 7 studies looking at nutrition outcomes and 7 at sexual health and HIV, and then a smaller number of studies looking at violence against women, 3 at vector-borne diseases, and smaller numbers yet at mental health, WASH, and health expenditure. It's quite important to note that of these 44 studies, 27 looked at outcomes for all eligible women and children in a population, regardless of whether they actually went to a women's group or not, whereas 17 looked at outcomes among group members only, and 2 looked at a sample of group members and non-members. And so this distinction is important because if we think of groups as a public health intervention, we either have to look at population level outcomes, i.e. for all eligible women and children, whether they're in a group or not, or we have to assume that groups include a very high proportion of women that would benefit from the intervention, or indeed that somehow the benefits of groups diffuse to non-group members. And these are quite important assumptions to keep in mind, and Sapna will discuss them a little bit in a minute. The majority of groups in the interventions we found were self-help groups. 8 studies looked at groups open to women, but also other community members, and with no membership requirements. And so we called these open groups. Other studies looked at community-based women's groups, which, as the name indicates, were for women only, but could be open or closed to non-group members. And then finally, a last group of studies looked at special population groups, for example, sex worker collectives. So they're very different kinds of groups in the literature, but most of the studies looked at self-help groups. As we examined the studies, we identified 3 ideal types of group interventions, and these have been mapped here by our colleague Lou Graham. So this simple typology looks at two main axes, the style of social and behavior change approach on the y-axis and the scope of capacity building on the x-axis. In the first ideal type, which we called the classroom, the idea is to mainly build individuals' capacity primarily by giving them information. In the second type, which we call the club, the idea is to leverage the group dynamics and build group capacity, which can be done by giving information, but also by engaging group members in problem solving. And finally, in the third type, the collective, the group actually becomes a lever to build community capacity beyond the group membership. And here we tend to see a much bigger emphasis on collective problem diagnosis and problem solving. This is a very simple typology, and we're not claiming that it's perfect or reflects all situations, but we're mainly using it to think about clusters of group interventions and their appropriateness in different situations and for different outcomes. Much to our surprise, we thought that we would find more classroom type interventions, but actually more studies in our review use the collective type intervention, fewer use clubs, and fewer still use the classroom type approach. So let's have a quick look at the results by health domain, starting with RMNCH. So here we found consistent effects on self-reported behaviors across the different types of interventions, the class, the club, the collective, particularly from studies looking at perinatal practices. And we've put an example by Saha and colleagues who looked at the effect of giving health education to self-help group members in Karnataka and Gujarat and found an increase in institutional deliveries, but there are many other similar studies out there. We only see effects on hard health outcomes, however, for example, neonatal mortality with collective type interventions. And this could either be because they're the only ones actually measuring mortality, or it could be because they're the only ones actually having an effect on it. So to look into this a bit further, here's an interesting trio of perinatal interventions, all conducted in settings with high child mortality. Tripathi and Eggjud colleagues tested groups doing participatory learning and action meetings facilitated by ASHAs, in which groups prioritized problems and strategies and then implemented their chosen strategies. And this had a strong effect on neonatal mortality. So that's one type of a collective approach to this intervention. Kumar and colleagues did a different intervention, but that can also be classified as a collective. They did behavior change communication with home visits and group meetings, which was developed after extensive community engagement in Shivgar, in UP, and they engaged with multiple community members as part of the interventions, parents, in-laws, TBAs, village health committee members, to really leverage individual, group, and collective action. And this also had a strong effect on neonatal mortality. The interesting thing, however, is that when they tried to scale up this intervention, as evaluated by Acharya et al., this time they only gave it to closed with mothers groups and mainly focused on disseminating health messages, much less emphasis on problem solving and much less community engagement. And here we found improvements in self-reported behaviors, but not on mortality. So the lesson here seems to be that if you want improvements on hard outcomes like mortality at a population level, then collective type interventions that by nature engage community members beyond the group are possibly a better option. Turning to nutrition, we found consistent changes in self-reported dietary diversity and breastfeeding practices for women and children in several interventions, including the intensive health and nutrition BCC provided by the Jivika community mobilizers to self-help groups in Bihar, as evaluated by Gupta and colleagues. We didn't find evidence that SHGs could, on their own, improve women and children's nutritional status. Deniger and colleagues looked at the effect of the federated self-help group program in Andhra and found that it improved energy intake among group members. But this was only, well, they hypothesized, possibly because the group and the program included rice credit lines and specific group funds for dairy producing livestock. In other words, there was direct nutrition inputs. Only one intervention plausibly improved children's anthropometry, and this was participatory learning and action combined with home visits, but critically also creches with direct food supplementation for children under 3 in Jharkhand and Orissa, as tested by Gop and colleagues. So the takeaway message here for nutrition is that improving self-reported nutrition behavior seems possible with a range of group types, but shifting women and children's anthropometry only seems possible when nutrition-specific actions and inputs, here we had the rice credit lines, the livestock, the creches, are also provided. So these were our two big sets of studies, and now let's turn to our rarer outcomes. Overall, we found little evidence that interventions through groups alone could reduce violence against women. This echoes findings from global systematic reviews, and we could go into them into the discussion if you like. We found several studies that suggested positive effects of community mobilization with SHGs to help control vector-borne diseases. And here we've cited two examples on dengue and malaria, with impressive results on both objective measures and preventive behaviors. So this is an example of where working with SHGs led to effective community mobilization and change. And finally, we found strong evidence for community mobilization to improve sexual health. Belonging to sex worker collectives, for example, is associated with decreased STI prevalence and increased condom use. So this completes the sort of wrap-up of findings from the experimental studies. But which dimensions of group interventions are linked to positive effects? We've made these three simple plots to map three different dimensions of group interventions and the proportion of studies with positive effects for each of their levels. So the first looks at levels of community participation. And the first level is just informing members about the intervention, giving them little say in how it's implemented. The second is consulting the community in the design of the intervention, but with external parties retaining most of the control. And the third is about establishing a partnership with the community to design and implement the intervention. So we found more studies with positive effects as level of community participation increased from simply informing or consulting community members to actually building a partnership. Similarly, we found more studies with positive effects when interventions aim to increase community capacity, not just individual or group capacity. And finally, we had more studies with positive effects through open or community-based women's groups compared to special population groups or indeed self-help groups. So this is quite a crude classification of interventions, and it's based on the information that was given by the authors and our own judgments, so it has limitations. But it suggests that moving away from simple information transfer towards building partnerships with communities and building community capacity, almost regardless of group type, is a better way to go. So I now return the floor back to Sapna to talk us through enablers and barriers in more detail.
Thanks, Audrey. So we synthesized all of the high and moderate quality quantitative studies and the qualitative evidence to identify enablers and barriers to achieving health outcomes in three main areas. So this slide is an overview, and I'll go into a few areas of detail. So the first area around enablers and barriers was contextual factors. For example, rural or urban setting. We did have fewer studies in urban areas though, but we identified issues such as migration or the presence of existing groups as factors that mattered. The second area was around the design of interventions and their implementation. So for example, through our analysis of social and behavior change techniques, we found that interventions that used a wider number of techniques at both the individual and social level were much more effective than employing an individual-based nudge approach, for example. We also examined the stability of the underlying group or implementation processes. So how regularly did women attend meetings, or how long meetings were for. And the third area was the characteristics of the outcomes themselves and the areas which groups chose to work on. So I'll talk about that one in more detail. So the first question is whether the outcome itself is relevant to enough group members. Now that really depends on the composition of the group. So for example, in a situation with NRLM developed self-help groups where the mean age is 38 and 2 to 4 women may be pregnant or lactating, Gupta and colleagues found that it was difficult to sustain the interest of women during longer meetings because it was only directly relevant to a few of them, and therefore the intervention effectiveness really depended on diffusion, for which there's not much evidence till date. The second factor is whether the mechanisms themselves are plausible, as Audrey mentioned with violence against women. When an outcome is it's linked to deeply embedded social norms, an intervention that doesn't engage the community more widely through a longer period and mobilization approaches may not be as effective. Similarly, what we saw with nutrition, with linkages with supply. And lastly, we looked at interventions across the board that address more than 2 outcome areas. We saw no evidence of effect. Interestingly, for example, the Gram Varta intervention and evaluation in Bihar aim to address violence against women, hygiene, RMNCH, including family planning, and found no evidence effect. And others also commented through process work that perhaps it was the dilution effect, essentially not being able to work on one outcome area intensively in other interventions. So the second area of interest with enablers and barriers was around the characteristics of facilitators. We generally saw 4 types of facilitators employed in interventions. The SHG member, for example, or the SHG community mobilizer, who of course know SHGs well, or a local woman who's been externally recruited and can be a trusted source of information, but is not necessarily within the health system initially. And lastly, and commonly, is the use of an existing ASHA or community health worker. While all of these had advantages as well as challenges, as you can see listed here, we found on balance, keeping sustainability and effectiveness in mind, most effective interventions employed facilitators with 3 characteristics: trusted, motivated, and local women, and motivated both by payment and other support. Secondly, those who already had links to the health system so they can engage beyond information, but also engage women with access to services like ASHAs. And third, those who are able and capable to prioritize health and specifically have the time to prioritize health. Unlike women who may be facilitating savings and credit groups, for example, we found in several process evaluations the issue of not having the time to actually work on health because there were other competing priorities to which payment may also be linked. The third area that mattered quite a bit and came up quite commonly in the process evaluations we saw was challenges with intensity. And we define intensity here in 3 ways from what we found, what was reported. One is the length of the intervention itself, so how many months or years. The second is how frequently women met, whether it was a month or every couple of months. And third, how long the meetings on health actually were. So you see here, for the interventions we have information on, we compared open groups and self-help groups. And you see in the first few bars that several of them were 3 years, 36 months, but there's an issue with groups actually dissolving. So for example, in one of the self-help group interventions, 27% of groups dissolved. And though I believe that number is decreasing now with time, it is an issue to be cognizant of when thinking of duration of intervention is dissolution of groups themselves, depending on the underlying group and its own stability. Similarly, when we looked at the length of meetings by intervention type, we found that classroom type interventions that tended to be sharing information, using the group as a platform, so to speak, but the group was also engaged in other activities, such as with the Jivika groups in Bihar. Meetings were observed, and these are through process evaluations or observations, for 10 to 20 minutes, and these were typically once or twice a month. On the other hand, club and collective approaches, both with SHGs and open groups, that really aim to build the capacity of groups, not just for other issues that the group worked on, but specific to health and the health issue at hand, tended to be longer, at least an hour on health. So while we couldn't draw direct links between intensity to effectiveness, given the small number of evaluations that even reported these indicators, we found 3 factors common to most effective interventions. So one was a dedicated health meeting at least once a month. Secondly, a health discussion for at least an hour. And third, an appropriate duration of intervention. And of course, that's proportionate to the ambition of the intervention, so what it's aiming to achieve. And I'm going to close here with just summarizing our 5 key areas or principles to consider that emerged from the review on what made women's groups interventions effective in improving health outcomes. So first, the choice of outcomes, and I will add here who decides the outcomes. Is it women deciding their own priorities, or has it been decided externally? Second, in terms of expanding social and behavior change approaches, so going beyond the idea of a platform and information transfer, but rather engaging groups in participatory problem solving. And this requires time. The third is quality facilitation, as I recently just mentioned. The fourth is adequate intensity. And lastly, particularly if the aim of investing in women's groups is to improve population health outcomes, the groups must reach enough women, but also enough relevant women through the group, and also include the most vulnerable. And though these seem obvious, I must say they resonate with a personal lesson for me from about a decade ago, when at SEVA we experimented with essentially what I would call now a classroom intervention of giving women information, because we assumed we were harnessing the long-standing history of collective action with on other issues such as workers' rights and social security benefits. However, we learned that despite choosing relevant outcomes, just providing information wasn't sufficient. And that lesson resonates with, I think, the key message of our review, which is that if we want to harness the power of organizing in collectives and organizing women to address health, then we need to invest in the community mobilization processes that are shown to work, invest in participatory processes that are shown to work, specific to health, and not just assuming that power in one arena immediately transfers or is translatable to health. And at that, I'll close here. I recognize we've just given you a lot of information in a short period of time, so please feel free to reach out to Audrey or me. Our emails are here. We'll also share the paper with all of you who are registered when it's out, as well as post it on the website of the Evidence Consortium, which is here. So thank you all for listening.
Thanks, Sapna, and thanks, Audrey. So I know a lot of folks might have sort of joined in a little later than when we initially kicked off. So if you have any questions, comments, or reactions to what's been presented, you can use the Q&A function that you can see in your Zoom action bar next to the panelists, and next to the attendees, and the chat options. Sapna and Audrey, I can already see a question by Thomas in the Q&A box. So if you want to respond to that, either by typing your answers, that'll be great. So now, moving gears to the panel discussion that we wanted to set up. And I'd first like to invite Dr. Rajani Ved. I just wanted to get a sense from you if you had any initial reactions or any comments to what Sapna and Audrey just presented. Anything that surprised you or something that you would disagree with? Just curious.
So thank you very much, Sapna and Audrey, for a great presentation. I think a few things really stand out for me in the presentation, particularly from the point of view of the National Health Mission, because for 15 years, NHM, even at the start of the launch in 2005, focused on community collectives like the Village Health Sanitation Nutrition Committees, and much later in 2013, on the urban health groups called the Mahila Arogya Samitis. And they also introduced the community health worker, the ASHA, and it's been this sort of, I think, having been with the program for so many years, a constant source of partly frustration, but partly this grappling for answers on why the community health worker program progressed so rapidly and our work with the collectives didn't move forward except in a few states. And I think Sapna's and Audrey's presentation actually gives us some of the answers, not all, and throws up lots of questions for policymakers on how to engage with groups, both the groups constituted within the National Health Mission and also the self-help group environment, which is huge in the country. To me, 3 or 4 major things. One, what groups reach the most marginalized? Because at the end of the day, for our health system now, inequity and disparity are really the key challenges facing India. So how do you reach the marginalized and using the group process? I think the second is, how do you address urbanization, collective functioning in urban areas, which is a huge challenge given nearly 40% of India is in urban areas. The third is this notion of closed groups or special support groups. Increasingly with the epidemiological transition, we are looking at a high prevalence of chronic diseases. And there is some evidence in the field from a few small labs on patient support groups for hypertension and diabetes having an influence on treatment adherence and lifestyle change. And it would be really useful to see how we could apply some of these learnings to those groups, which are really very fledgling. I think the point about facilitation is really strikes a very strong chord, whether it was the ASHA program or whether it was successful Village Health Sanitation Nutrition Committee functioning. I think the single most important factor was strong facilitation, either by the state or by NGO groups. And maybe we'll explore this a little further as the panel goes on. But I think overall this paper, this presentation, I think needs to be heard by policymakers, both within the health ministry as well as within rural development and urban affairs, to really figure out how to engage with groups and I think just one final thing is about social and environmental determinants. So when health systems become functional, overall people's access to health systems increases, except of course the really marginalized. But action on social and environmental determinants it's my understanding and actually my experience over this is that unless you have strong community collectives, you will not be able to take much action on them by the health system alone. So I'll stop there for now, Ashwin.
Well, thanks, Dr. Rajani. I think you touched on a couple of interesting points that I want to sort of just draw the line further on those. One of them is you mentioned that, given that you've also been the architect of the ASHA program and you've been really driving for participatory learning approaches through ASHAs, you mentioned that, there are states where these collective approaches seem to have worked better. And I think just based on your experience, what do you think, at least either from a community lens, really facilitates these approaches to work well in the states where they seem to have gained good traction?
So, with the PLA work, it's been scaled up in Orissa, Madhya Pradesh, and Jharkhand. And while in Orissa and Jharkhand, the originating agency in India was really Ekjut, and they work very closely with the state. In Madhya Pradesh, it's slightly removed. So Ekjut is working with the state government through local community-based organizations. And very interestingly, they chose 17 districts where all of them are tribal. And in the 3 years since they've worked, and I'm only quoting from monitoring information systems data, is that there have been improvements in antenatal registration and institutional delivery, in reduction of home deliveries, in retention of IUCD as well. Those are the 4 indicators that I picked up. But I think the success factors here, and one has to say that a functional health system is also, in addition, you can't just have facilitation of groups and have groups act. Maybe home self-care behaviors and some home behaviors improve, but actual coverage and access of services only improves when there is a functional health system. And so I think the two come together to do that. Our work with the PLA in Madhya Pradesh also shows that earlier we always thought you needed to be health-related NGOs that had to work on health. But in Madhya Pradesh, a lot of community-based organizations that didn't have experience in health but were mentored, but had very strong, credible community rapport, were able to actually support the facilitators and the ASHAs to undertake the PLA meetings. And so I think that's another big learning, because often the rate limiting factor for scaling up with NGOs for such intensive processes has been the availability of health NGOs. And now if we can look beyond health NGOs, we really have a larger pool to draw from. So I think that was one important learning from PLA. But it also tells you that you cannot, for instance, continue to say you'll have to rely on factors other than the health system. So even though the ASHA program has a dedicated support structure for community processes and for strengthening the ASHA herself, we do need facilitation of other kinds if we have to engage with the community collectives. And even in the village health sanitation nutrition committees, where panchayats were strong, the VHSNCs took off. So in Kerala, in parts of Orissa and parts of Karnataka, it happened, but there has to be not just a facilitating individual, there has to be a facilitating institutional mechanism that makes it happen. So that's our learning from PLA. But I'm a little, I think, disappointed that the PLA work didn't go beyond the states where there are large tribal populations like Orissa, Madhya Pradesh, and Jharkhand. Our challenge is really to move it into urban areas. And I think, as Sapna and Audrey both pointed out as well, the findings from urban areas are not that positive. So we have to figure out what ways of engaging community collectives in urban, and it's difficult. There's heterogeneity in urban, in tribal rural areas, there's more homogeneity of populations. So I think, and one final thing, I think the reason why ASHAs working with collectives in these areas have succeeded because they're also health system actors and they're community agents. So I think the two together, so I think if you bring in just a community functionary or a community resource person or a community organizer like the Livelihoods group have, with no linkage to the health system, you may not see some of these effects.
Oh, and very, very valid points. I'm just curious also, do you have any take on whether you see, let's say, women's groups programs, sort of just moving away from the ASHA and the PLA approach there, do you see women's groups programs being more facilitative for certain kinds of health behaviors, maybe things that can be practiced individually by an SCG member versus something that requires, like you mentioned, supply linkages to the health system, like institutional deliveries maybe, or maybe something that requires a lot more collective decision making by a household rather than an individual SCG member themselves. So I'm just curious, your take on which kind of behaviors seem more amenable through these kind of group-based programs?
So I think both, as the study pointed out, and plus our own experience in the field, is that if you look at the average age of self-help group members, and I think that point was very well illustrated, and if you have women beyond the reproductive age group within your group membership, you're relying really on diffusion to change behaviors, and that may not be so effective. I think the second also is that, but then it has potential for the newer areas that we're entering in, such as chronic diseases, mental health, etc. I think there's also, I'm not sure how much either the PLA work that we know very well has actually resulted in enforcing accountability of the health system. Because that has a really important bearing on the supply side mechanism. And you can do all the demand you like, but if the group is not empowered enough to hold the health system accountable, it's happened in Maharashtra and some places with the Community Action for Health groups, where the focus was on enabling accountability, and it had mixed groups. It didn't have just women's groups, it had both men and women. It worked. So I think when the agenda is accountability, then you can enforce, you can demand from the system, you can hold providers accountable, you can make sure entitlements reach people, but that is a very specific agenda. And I think the point that Sapna made is, what is the content of what you're doing with the groups? You know, does it emanate from the groups, or does it emanate from our agenda? So I know many years ago, I worked with women's groups, and my focus was all on maternal and child health. And the women kept telling me that mental health and suicidal ideation are very important factors in that area, coming from poverty, unemployment, etc. But then my agenda was driven by a particular program that I had, as many of us do. And so I think this point about getting women to articulate their concerns, although that's a very intensive process and sometimes it may not match with the programs, but how do you achieve a balance between that? I really think with primary healthcare reform in India, there is a possibility of getting all these factors conjoined together. So you do have a platform, you can do maternal child health, but you can also address chronic diseases and acute emergencies, etc. Thank you.
Thank you, Dr. Rajani. And that actually sort of creates a very interesting segue. I'd like to call in Dr. Vijayendra Rao. I know that you've worked extensively on sort of the entire space of accountability, government accountability in citizens groups. And I think just piggybacking off what Dr. Rajani just mentioned, it'll be great to hear on your perspective whether government-sponsored group programs like the NRLM or SHG or SRMM SHG groups can really hold other government departments like the health department accountable for services that they're meant to provide. And also just any reactions or thoughts that you have from what Sapna and Audrey presented would be great to hear from you.
Yeah, thanks, Ashwin. And thanks. It's very nice to be in a panel for a change where I'm the only man. So it's great. But I'm going to draw on that, but I'll also draw on my 8 years working with Jeevika in the early phases of Jeevika. And so I think let me reflect on those things to reflect on this very nice review that was done. Firstly, I really like that classroom club collective distinction that you had. I've not seen that done before. I always get jealous when somebody comes up with an idea that I haven't come up with. So I'm jealous. That's great, and I'll steal it. I think the approach you've taken, which is to really be quite eclectic in what you've considered evidence, with both qualitative, quantitative, descriptive, evaluative, RCT, non-RCT approaches. I think that's a very healthy approach. So please don't call it a systematic review. That gets me very irritated because that doesn't take that approach. Yeah. So call it for what it is, which is a review of the evidence as you see it. Couple of thoughts. You must be aware of this wonderful 8-part series of evidence reviews of community-based approaches to health that was done by Perry and his colleagues at Johns Hopkins some years ago. I don't see it cited, so maybe that's because I haven't looked carefully enough. Their findings are very, very similar to yours. And they say it's an international evidence base, but most of their evidence is from India. So, you might want to contrast what you found with what they found. I believe it was Lancet, I may be wrong. Okay, so coming back to a few themes that come up that I think one should watch out for. How much time do I have, Ashwin, before I spurt off?
We have till around 7:30 for your points as well as Dr. Purnima's sort of Q&A there. So maybe about 10 minutes, yeah.
Yeah, okay. okay, so in doing this kind of review, there's sort of several things to keep in mind. The most obvious point is looking at studies that are proof of concept studies, that are looking at designs which are, boutique interventions done for the sake of evaluation versus looking at large scaled up programs. At least in the presentation, that didn't come across. So I would be interested in teasing that out a little bit more. Secondly, health is not the only thing that, say, NRLM groups do, right? Nutrition is not the only thing that they do, as Rajani was pointing out. They're doing a whole bunch of different things. I have been a long-term critic from the Andhra Pradesh approach, old AP approach of parallel structures in village government. And my concern is what's happening in Bihar is something similar. There's a lot of talk of convergence, but it's not really happened. So what's happening is that the sort of constitutional structure is being violated. The 73rd Amendment is getting violated by getting these groups, giving them all this resources and the money to do what they do without paying attention to the panchayat system. Getting them integrated, as was done in Tamil Nadu and Andhra Pradesh, and to some extent in Karnataka, is Gujarat, is the way to go. And how do we get that to happen effectively? And as Rajani points out, that also makes them more effective, at least in the long term. So thinking short term versus thinking long term, building institutions versus trying to test for the sake of testing. And here I'm going to say something that might upset some of the people in the audience. I am just read Anand Giridhar Das's book, Winner Takes All. And I'm acutely worried about funding driving in the nature of interventions. We are all concerned with the same thing, of making people's lives better. But really, they should be done in the interests of the citizens of that country, and therefore the elected representatives of those citizens, bringing community voices into the picture, male and female. Yeah, it cannot be driven by somebody's agenda who decides women's groups are the way to go, and we're going to shove a lot of money through that, and then everybody has to go there because everybody's scrambling to get that money. Yeah, so part of my concern with why is there a health systems review and not a review of, say, credit effects of self-help groups is because the funding's there. Yeah. I'm not saying that there should be one, but I'm saying be aware. I think Indian citizens should be aware, as citizens everywhere, that there is this dynamic taking place that is coming from externally funded approaches, externally funded priorities. Now, having said that, the goal should be to create systems that change health approaches, how health is done for a very long time. The ASHA Workers Program is a wonderful example of that. Yeah. In Jivika, for instance, as far as I know, and I stopped working with Jivika about 2 years ago, so I might be wrong, but most of the nutrition and health interventions were done with Jivika Phase 1, which was where, if you read my work on this, Jivika Phase 1 is by far the best of the Jivika interventions. That was when they did all their careful, slow-cooked development of institutional structures. As Jivika scaled up, it sort of got a little bit, weaker, and as you would expect. So if you do something in Jivika Phase 1 and find it has good results, it's not going to necessarily translate to the rest of Bihar. Yeah, you have to be acutely aware of that when you start learning from all of these things. Similarly, when you're sort of looking at any kind of evaluative evidence, looking at sort of community-based approaches to evaluative evidence, and this is on the other side, when you see a result that is not significant or that is not seeming to have an impact, that might be because of the design of the evaluation. And keep in mind, self-help group interventions are necessarily extraordinarily heterogeneous. They work best, as Sapna, I'm sure, knows from her work in Seva, when in fact each village is different, is done differently, is approached differently, which means every village is a different intervention, in effect. Yeah. To evaluate a design like that, you need a humongously huge sample. Yeah. Which you don't have, never. Yeah. So what ends up is you end up underpowering your studies, and you end up getting results that look negative, or look if not negative, look with zero impact because they're not significant. When the lack of significance is about underpowering studies rather than a real lack of significance. So what is the real zero versus something that's because your sample size is not big enough? That has become, to me, I mean, I did a book some years ago called Localizing Development that I think we were subject to the same criticism that I'm making of you. So I'm not sort of trying to, I say that I'm not subject to the same criticism. When you do a review, you have this problem in this field, which is that how do you evaluate the evaluative evidence? Yeah. And I think some thought should be paid to that, is what lessons can we take from all of this? So, let me stop there. There are other things I want to say, but I think I've crossed my 10 minutes. So let me stop there. Bottom line, I think, so final thing, if you look again at the Perry et al. 8-part study, their last paper was a 5-pager summarizing all the results for policymakers, the big picture, basically the last slide of your presentation. It'll be really nice for you to do something like that, like a note that everybody can read, and we don't have to have PhDs to understand that that will help the policy dialogue. Being self-critical of yourselves in this whole approach. I mean, what I worry sometimes with all of us researchers is that we tend to say that we are telling you the truth. I think it's important to be self-critical of the approach itself. Yeah, but along the lines that I've suggested, and I hope I'm criticizing myself as I'm doing you in doing these things. So I think that would be a useful next step to this. Thank you.
Thank you so much, Dr. Vijayendra. So we will sort of leave, about 5 odd minutes for the other panelists to come in and sort of weigh in on what either Dr. Rajani has mentioned or what Dr. Vijayendra has mentioned. But I'd like to sort of turn to Dr. Purnima and sort of get any reactions or thoughts that you might have based on what Sapna and Audrey presented so far.
Great. Thanks, Ashwin, and congratulations again, Audrey and Sapna. So firstly, thank you guys so much. It's really wonderful to be here and to have had a chance to pre-read. I did read the review and see your slides and everything. So I want to say firstly, congratulations on the review, because I think it's taken the conversation forward to the right kind of place, where we don't just say self-help groups work or don't work, women's group work or don't work, but we're, you've sort of moved the conversation to a place that says not just do women's groups work, but what is it about these groups and that makes some things work, right? And what is it about those groups that make some things not work? And then what is it about the connections between what happens in those groups and what happens in other parts of society or other parts really of the policy landscape, whether it's connections with entitlement programs or whether it's connections with health programs. I think you've made the right kinds of connections, and I really I valued seeing that, because it's very resonant with our experience on looking at nutrition behavior change. We don't ask anymore, does nutrition behavior change work, right? We ask, what are the conditions under which it works? What are the characteristics of interventions and programs where behavior change works well, and where is it that it doesn't? And I think you touched on, and when I say behavior change there, I mean the more standard interpersonal counseling and communication delivered by frontline workers, which is different from the group-based approach. And I think what you unearthed in the review, which I really liked, is that the same principles as one sees in many other sort of bodies of literature about interventions and what makes them effective or not are sort of revealed in this review as well. And they're revealed for a context where the idea of these group programs has somehow taken on so much salience. And I think, Viju, you asked good questions about why do certain things take salience at a certain point in time or not, but the fact is they have, right? And so those principles are, the principles of, what is the nature of the group? What is the intensity of the engagement? Programs that are effective are often doing more than just building knowledge. I mean, when we talk about effective frontline worker programs to say support breastfeeding, we know that the best programs that work are those that also build skills that help coach mothers, that problem solve for mothers, instead of just telling them you have to breastfeed your babies for 6 months. We know that variety of programs don't work. We know the ones that work actually have this sort of a deeper sense of what it actually takes to do something. So I really liked all of that, and I think it would be interesting for you, maybe not, the paper's written and you're probably close to submitting it, but in the broader policy communication, perhaps to also think about and make those connections to other bodies of literature, right? So I'm reflecting also, for example, on, there's been so much work on what makes cash transfers work for health or not, right? And it's almost the opposite here. So with, these group programs are sort of information, motivation, skill building programs. And what we say is that, but you need some additional resources. You need those entitlements, you need the food transfers or the cash transfers to make it work better. When we look at those programs, we actually say the other side. We say, listen, it's not enough to just give cash. Or you have to kind of build in some other components that actually close the loops and make sort of different parts of the jigsaw puzzle fit. So I think we would do well in policy communication and in sort of program engagement to actually connect the dots with these other bodies. But I think we have to ask some of the harder questions. And so Biju, I like what you raised about, Anand Giridharas's writing, because I think we have to ask what else can society do to give us these outcomes we care about. One of my big concerns with, often group-based programs and other things is that there are many of us in the same societies who have benefited from those outcomes without needing to put in the hard work that goes into these group-based programs, right? There's a certain there are segments of society that don't need to do the hard work, that don't need to go to monthly group meetings, that don't need to solve their own problems, because somewhere else those problems have been solved for us by virtue of where we sit on economic spectra, what our access to other healthcare we have, and things like that. So I also think that some of those philosophical issues must be asked somewhere. I did want to raise a couple of things that may still be worth reflecting on in your review itself, and that is to ask, whether you've sort of unpacked the characteristics of the specific behaviors that the groups are going after, and sort of being a little more explicit there about which are the behaviors that are truly amenable to change. And I know there were threads of those conversations before as well. And the other thing, which actually I don't think I saw either in the paper or in the presentations, you should correct me if I just missed that, is the characteristics of the client populations, right? Rajani, I thought it was really interesting that you brought that up in your comments as well, the fact that these have been successful, where there's been perhaps a more, in a sense, a more homogeneous client population, or perhaps a client population where other options didn't exist, but for them to try and sort of engage and problem solve on their own. And so I think that's really worthy of some reflection also. Maybe these groups won't work in urban areas because, not just because people are busy, but in fact, because people have other ways of solving those same problems or have access to other options. So, so I do wonder about that. And then I guess the last comment I want to make is, when you look across sort of the range of different behaviors, the range of different outcomes, and juxtapose that with the kinds of groups, I too really liked the classification of the groups. I also found myself asking, is there room for all of these groups? Is what we want to pull out of the review something that says that, oh, no, it's only this kind of group that's the best? But I also ask myself, sometimes you can't create that kind of a group that works the best. So what do you do with your next best option? I should make one small correction. The Jivika groups were all 90 minutes long, probably, in their durations. I was part of the process evaluation where we did those observations. It's just that they could only get 10 minutes in for the health conversation in those, right? So the group interaction was still as long as it was in many of these other groups, but there was so much else going on there. So, we can say an hour, but you're never going to get an hour on health in a Jivika group, because that's not the purpose necessarily. We want them to do more, but that's not the purpose. So anyway, let me sort of leave us with, with some of those questions. And, again, I really want to congratulate you on sort of doing a review that creates this very important set of conversations. And that in itself, I think, is a real big contribution here. We have to make those conversations happen to say, what is it we can do, want to do, should do, and how with group-based programs. So yeah, thanks for the opportunity to read, be here and comment. And I really look forward to the rest of the conversation today.
I don't know, Sapna, Audrey, do you have any immediate reactions or responses to what's being flagged, or any points of difference in opinion. It's trying to be a little provocative here, but even from the other panelists, any difference in opinion or agreement with what the other panelists have mentioned before we get into the Q&A. We have about like 3 or 4 minutes just for like wrapping up the discussion piece. So
I think I'll just raise 2 quick points and then I'll turn to Audrey. One was the very important issue of scale that Biju raised. So several of the interventions were poised for scale because they worked with government health workers, for example, with ASHAs, or they were assuming that this is already an intervention that was, again, positioned for scale because it's through a government program. A few, I think today we are seeing increasingly programs working at scale and evaluations adapting themselves to, either by using administrative data, for example, as I know Audrey and colleagues are doing in one state as well, in order to assess the effects. And I think what's important to remember with all of these, that we need outcomes that are similar to evaluate, even at scale. So for example, if there is mortality data available in a state at scale, it's important to use that are data already being collected to evaluate these larger programs. And a point, Purnima, that you raised about the different types of groups, I think what we found, what was so interesting was it wasn't the type of group underlying that determined if it was a class, a club, or collective. Actually, even with Jivika, we saw an example of all 3. We saw the classroom where they gave information through flip charts. You saw the club that Shireen Jijiboy and colleagues did around looking at working on violence. You also saw the collective approach tried through the Gram Varta. So it's not the group, it's more about the choice in terms of, it's almost a philosophical choice perhaps around who decides priorities and then in which way the intervention proceeds in terms of how participatory it is as well. I'll turn to Audrey. And thank you all so much for your careful reads.
Yeah, thank you for a cornucopia of amazing thoughts and comments. I want to go back to the class, club, and collective distinction. And I think the reason we developed this is because we saw a disconnect between what a lot of the interventions were aiming to achieve, sometimes quite large-scale changes in behaviors or hard health outcomes, and what they were actually doing. So the prototypical thing being the 10 minutes in the Jivika group. And so while, of course, groups are not just there for health, and of course there are constraints in terms of what you can do, you kind of need to align the ambition with the intervention in a sense. And so that's, that disconnect is, I think, what we were trying to get at when developing this collective. And so really pushing towards recognizing the importance of that building community capacity, which I think almost everybody in this group is sort of on the same page as, but we're still seeing large-scale programs that unfortunately function as mainly as about giving information in a didactic way. And I wonder if this is still okay, and if this is still acceptable, or whether it actually needs to change, and if so, how do you go about changing it?
Before we get into the sort of questions that have been posted so far, any sort of final comments or rebuttals from our panelists, or should we dive into the Q&A?
So I have one small thing I forgot to ask you is whether there was, in any of the analysis, you were able to look at sort of caste match between the facilitators and the community groups, and the extent to which that may have either supported better outcomes or not. I'm really struck by there's just this explosion of literature both within the US on race matches between providers and clients, and just a smattering of things being written about in India around that. So I was just wondering whether that's you had that lens anywhere and could speak to that.
I think we froze for a second, sorry. Purnima, I should note that we only had 14 process evaluations out of the 44 experimental studies, which is unfortunate, and many more evaluations must adopt. And what we didn't go into comments around the measurement approaches here in this presentation, but without interventions reporting on a lot of even just the characteristics of facilitators, it was difficult to take that lens. And I agree it's an important lens. We do know with ASHAs, for example, there are issues around reaching the most vulnerable, and that would be an important lens to look at going forward. So I would say to evaluators as well who are interested in these issues and other interventions, the accompanying qualitative and process work will be critical. Audrey, do you have anything from your work with IGJUT that might point to that though?
Sure. I think this goes back to Rajani's point about equity as well. And certainly much of my learning from IGJUT has been to try to build in equity as a concern by design. And one of the ways to do that is clearly to align the background of the facilitator with that of the group members. Also to think about the geographical location of the group. So for example, locating groups in hamlets where some of the families that you might want to reach might live, and of course aligning the kinds of materials that are used to the literacy and to the interests of the group members. So these are all sort of ways with which to think about equity by design, as you'll know better than me.
Can I just make one quick point that occurred to me as you were talking? A couple of times, Purnima and the authors made this point that the Jivika intervention was 10 minutes in 1 hour or something. And you all were sorry about that. You wanted a longer amount of time. I see it completely differently because those Jivika groups have to do an awful lot of important things. That is alleviate poverty, improve governance, empower women, all kinds of stuff, right? So my question is, I think people need to start studying the extent to which focusing on one type of thing in an intervention crowds out, either substitutes or complements other things. Yeah, I don't think there's been any work done on that. So just something to throw out there for all the young people watching or hearing. That's something to think about. Sorry.
Please.
Can I also maybe respond to some of the things in the chat, in the Q&A, I think which Vijay, you raised just a minute earlier about powering evaluations for different types of outcomes, and the fact that some impact evaluations may not be powered to effects. So in this review, we only looked at the primary outcomes as stated by the authors, and that includes in the quasi-experimental studies. But the problem is people often looked at 15 different outcomes, and obviously they weren't powered to measure effects on that. And that's a problem. And I think it's a responsibility of evaluators to do much better and not set interventions up to fail by putting out too many outcomes and not powering their evaluations well enough. I think the fault is on us as evaluators in doing that. So if we want interventions that have impacts on 10 different outcomes, we have to power the evaluations adequately to be able to detect those. I agree with you, it's a huge problem.
So just to sort of keep us on track in terms of time, if the attendees have questions, please use the Q&A function in your Zoom action bar to post questions. We already have a few to get us started off. Thank you, Audrey, for actually answering 3 of those questions in the chat itself. So one of the questions, and this again is open to our panelists as well as our presenters. The first question is from an anonymous attendee. Have you seen differences between pre-existing women's groups and I'm guessing the newly formed women's groups? I'm guessing that's what the question might mean. And could you explore or discuss the issue of social cohesion? Is it an enabler to women's groups?
Yes, I can try and take that. Yes, there is a big difference. Groups need to mature. And that's one thing. The second thing is, and Jivika is a prime example of this, when you start a new intervention, I remember Jivika started in 2006, and essentially Bihar had not seen much for many years at that point. So everybody was extremely excited, and we had this chief minister who was completely behind it, and the chief secretary, that a lot of attention was paid to doing it right in phase one. And those groups in phase one have become the leaders of the self-help group movement in North India. As the phases went forward, we actually have a paper on this, as those interventions scaled up, it got less and less good. It's still very good compared to what was there before, but less and less good. So there are two reasons why new and old groups might see a difference.
I think the second question that Neeta has also raised might be something that's relevant to what you would mention, which was, given the current focus of SRLMs working on scaling up, what are your advice based on these findings? And it's one of the points you touched upon, which is phase one was fairly intense, and the quality of groups at that time were of a certain type. And as you move towards scaling up and sort of and pacing of the program also does matter in that context. What is the broader advice that's in store for SRLMs who are working at scale? And this is open for anyone to answer this.
I mean, I don't want to be the only man talking. But Purnima says
it's open to anyone.
Well, I think maybe the issue to look at there is what are, if you take some of the concepts from the review as well, which is that the behaviors have to be relevant to everybody in the group, that they have to be doable with sort of minimal linkages to other resources. Maybe there can be some sort of levels of prioritization, either with the groups themselves, the representatives of the groups, or people who are engaging with the groups, to say, what are the two or three or four things that where you really do want to achieve scale, and that they're sort of more easily doable, and where you can engage, and where they're more sort of generally applicable. I mean, we live in a time where there are certainly a certain set of behaviors we are looking for today from populations at large, whether they be, wearing masks, or, getting people sort of on board with this idea of, keeping distance and, personal space or whatever else, that don't rely on age or gender or, in some cases, yes, capability and other resources. So honing in on some of those, I would say then make the scale of SRLM powerful. But if what you're trying to do is say, okay, we want to use that to address, big mortality impacts and this and that, I mean, I would say that, this review doesn't support that. But I'm going to let Audrey and Sapna say whether, what they think, because I'm interested in, in hearing what you guys have to say about that.
Can I make an additional point on the scale point? What worries me greatly is that so many SRLMs are under WDC and not under RDPR. Yeah, that has to stop. I mean, it's madness to have these two outfits, two ministries, two secretariats, essentially working at odds with each other, has been the biggest bane of rural development. And I mean, it's a terrible thing. And I know some states are trying to integrate it and getting prevented by the center for whatever reason. This is not about political parties. This goes back a long, long time. This bureaucratic competition on this. It's completely self-defeating. Yeah, SRLM should be under RDPR, and that will permit institutional structures to build just naturally and lead to more long-term outcomes.
Ashwin, if I may make a point, please, here.
Please go ahead.
And I think that, we have to create the institutional structures. And I agree with Dr. Rao on this, that it has to be under RDPR. But even if it's under RDPR, we've seen that only in states where panchayats have a long history of capacity building, like Kerala, like Orissa, have the village health sanitation nutrition committees really been effective. So it could be an RDPR for all that, but unless there are effective linkages and aligned incentives with the health sector, with nutrition, with WhatsApp, you will still not be able to see those population outcomes, the health outcomes at least. So I think that creating the institutional arrangements, and certainly RDPR is perhaps the most likely home for these people. But beyond that, you need to have those linkages at the community level, at the block level, at the district level. And as Purnima says, maybe the prioritization, even within a state, is different across districts. But that needs, and at scale, there's a little bit of incongruence between having multiple outcomes and goals for groups within a state or a district, and that's a really hard thing to do. But then again, intensive process facilitation is required, and you cannot do it with the kind of human resources we currently have devoted for this. We just have to say that we need more people to do the facilitation. It's just like in health. 15 years ago, people thought one auxiliary nurse midwife can address the needs of 5,000 people, and now we are now at a team of 8 people. That's what it takes to get that done. And so if you want, it's not enough to create institutional structures. You must have the human resources to back it up and the institutions to build capacity of those. Why does no SIRD have a module or a capsule on health for its members? Very, very few SIRDs actually invest in capacity building for health, social determinants, environmental determinants of the Gram Panchayat representatives. All of those things have to come together for your SRLMs to be effective, even if they're located in MOPR.
Point very well taken.
Excellent.
Could I ask Rajani also if you could, I'm sorry, I'm adding a question for you to respond to with respect to the question on the SRLMs. Could you comment on the issue around convergence, given that you essentially have these 2 programs operating in some states where SHGs are getting information, and also you have ASHAs facilitating PLA through groups?
So as I said, the PLA work is in Orissa, Madhya Pradesh and Jharkhand at any level of scale. In the rest, it could be small, spotty stuff that we don't know, but at least through the National Health Mission, it's being supported in these states. And I think there, it's a combination of the 2. It's not the SHG groups alone that are working on the PLA, right? It's the open groups, it's the plus, SHG plus. And there has been very intensive process, capacity building of the ASHA facilitators and the ASHA, both from the national level, the state level, and the NGOs involved. And you can see the level of interest. But unless this kind of focus, and we have additional incentives for the program, unless these are continued and sustained, this kind of convergence will not sustain. It's quite true. And we can see the difference when you, and also I must say, you have to have strong leadership. I think Dr. Rao mentioned at the beginning of somewhere that there was a chief minister who was interested, there was a chief secretary who was interested. In Madhya Pradesh, we had a principal secretary health who was extremely committed to PLA and decided that she would go for it come what may, despite negative press releases, etc. But that kind of commitment has to be sustained, and it has to go down to district and sub-district levels. Otherwise, you can't have one principal secretary committed and hope for multi-sectoral convergence to happen. It's a lot of pieces on the board that all need to come together. It's not an easy thing to do. It's even harder than getting the ASHAs to do home-based newborn care visits, and God knows that was hard enough.
Just moving along the questions that are in the chat. So Gayatri has raised this question, which is when looking at SHGs, have any of the studies taken into account how well the SHGs are functioning, not only in health, but thrift and credit, for instance? And the second part of the question is this generalizable across states as well? Could we say the same for SHGs in Kerala or Tamil Nadu, for instance? My suspicion is it's not, but I'll let Audrey or Sapna weigh in.
Sapna, I think you can speak to the SHG literature more than me.
Several of the studies reported on issues like group dissolution, for example, which we did see there were issues. So in terms of the quality of functioning, it was more around whether the groups were active or not. There were a few that looked at outcomes outside of health, which I think addresses one of the questions in the chat. But for the most part, the assumption was that these groups are well functioning. And what was interesting when the results emerged, one of the justifications for it not being would be that the groups didn't meet frequently enough, for example. And that actually calls into the point, I think evaluators that work on health also need to take into account considering the group itself and understanding its function, even in just the basic description of the intervention. We saw a very wide range of quality in terms of just describing interventions, particularly when it came to the group. I've been working with many colleagues, many here and also probably in the attendees, on developing a kind of really basic list of indicators to track with groups, because I think it'll help answer questions like that. But I think the biggest issue with group quality is really just whether the groups meet, and if they meet frequently enough and then are active enough to address issues on top of their primary purpose, which is absolutely savings and credit in the case of SHGs. In terms of generalizability, no one looked at it in particular. I think it's safe to say no. It probably isn't generalizable for the very reasons we looked at in terms of effective principles of interventions. And again, the group's readiness, their linkages with the panchayat. And I think that's a really important point to think about when addressing health as well, is what are the linkages with other structures that address health and influence health. We haven't seen research, and that's also a question for others to look at, is not just focusing on these 3 or 4 states, as you saw, where a lot of the research and funding happens to be.
Great. I think Abhishek's comment is a response to a question that Indrajit had, so let me mark that as done as well. Aishwarya raises the question of, could you speak a little bit further on whether the interactions between financial or economic or livelihood programming and health programming within the group differentially improves women's health outcomes or not? I think this sort of maybe alludes to your observation on the implicit outcomes that certain interventions or programs are stated to work towards. I think the question is whether specific health programming differentially improves health outcomes versus financial or economic or livelihood programming.
Well, I'd like to respond to something, and then I think Purnima should also speak to this, given your work. This movement or this idea really began, I think, a long time ago, and at SEVA we certainly believe this as well, that working on these issues was sufficient to assume improved health outcomes amongst SHG members or women who are members of collectives. When that didn't necessarily bear out with evidence, there was this idea of, oh, why don't we add on some health to this existing financial activity? Thus far, the evidence has not really it depends on the type of intervention that's added on. So the assumption that there's a group that's engaging on other issues, like in the experience I mentioned at SEVA, and certainly with self-help groups, a group even really well functioning on finance doesn't mean that that group will automatically take that social cohesion, or that if they've engaged in collective action, and transfer that to health simply by giving them information. However, as we saw with the work with vector-borne diseases, those were SHGs that really functioned in Tamil Nadu, for example, in urban areas, that were then mobilized successfully within a larger government health intervention as mobilizing to address an issue around social determinants of health. And I think that's a model we need to look at a lot more, where I think it's realistic, it's proportionate to ambition, but also looks at what is already there and mobilizes them for what is possible, as opposed to ambitions that might not be matched by the intervention approach.
So I'm only going to come in here, Sapna, because you said that I should come in. I actually wanted to ask the question of, if we juxtapose the literatures, you have this thoughtful review on the impact of bringing together these groups on, and the characteristics of what that bringing together itself looks like, and the impacts on health outcomes. And, I think we have to juxtapose this against the reviews of, the other outcomes achieved by these different kinds of group programs, right? I truly want to know how successful has, for example, has Jivika been as successful as it possibly could have been on economic outcomes and livelihood outcomes for women. I mean, what we've seen, I think from the Pradhan groups and some of the others, is that a lot of the savings amounts and things like that are really small amounts of money, So is what else is happening around? How much is it, fulfilling the economic needs? And, does it need that to be fulfilled before we can start to engage and see, work with these groups on, some of these other outcomes as well. So, like any researcher, I'm just going to say I have so many more questions than, and we think there are many more questions to be answered here. I'm sure, I don't know if any of my colleagues who work on women's groups in agriculture are on, on the call, but it would be great to see maybe in the chat messages, what is one seeing from that literature on the achievement of these, these other outcomes? And then how much more can you add on? I feel like we've given the narrative of we can layer and it will work, maybe a little bit too much rope. I can see, a lot of nods around here. And, in some sense, the review is sobering and in a very important way, to say that if we want health outcomes or nutrition outcomes, we have to be very, very thoughtful about how the groups, which groups we engage with, how much does that outcome mean to those groups? Where does that outcome that one is interested in terms of health and nutrition, sit with the core purpose of those groups? Are the groups achieving their core purpose in the first place? And then we are ready to layer. Biju, I distinctly recall a conversation with you many years ago now when we started working on Jivika, where we were talking about building roads and sort of how pakka does the road have to be on before you can start driving other things on it. So I do think that this is a great moment and a really important moment to reflect on those many things, and the review helps us walk on that road a little bit.
Thanks, Purnima. Thanks, Sapna. So just cognizant that we have about 8 odd minutes, I think we'll probably take a couple of more questions and we'll just sort of then do a short wrap up. We have a question from Kala, and I think Thomas's question is also sort of in a way linked to it, which is which health interventions do you think are the most important to address health equity, and what study design do you think is the most effective for addressing health equity in self-help groups? And Thomas's question is one around which specific intervention components are critical before moving to scale, but were not feasible to implement with quality at scale. So, and yeah, so we'll take that and then one more question after that, and then maybe we can.
Do you want me to try and have a go at the health equity question? So that's a really important one. And I think it's really encouraging to see actually the growing number of researchers who are doing equity analyses as part of their evaluations and trying to understand differential impacts of interventions. I don't think we really know which interventions with SHGs are the most important to reduce equity gaps. And part of the reason for that is that we are not really designing evaluations to look at reductions in equity gaps, because it actually requires much larger studies than the ones that we normally design. But it's really important that we start to look at this in more detail. You've used the term health layering, but after Dr. Rao's comments, I'm wondering whether we should use the term health crowding instead of health layering, or some other term, because clearly the layering is not working for many people. So maybe we need to move away from that terminology.
Let me comment on the components for scaling up. The first thing, and this is going back to what Rajani said, the top has to meet the bottom. I mean, this is something we've been arguing for many years now, what we've been calling a sandwich. Without that, these remain boutique interventions. That means you should have government buy-in. And the second thing is, you have to think very long term, not very short term. I think in anything, I mean, yes, you can, I mean, as Purnima said, there's to date no evidence that Jivika has reduced poverty. Yeah. There is, we worked on a paper in RCT in second phase of Jivika, which is done at scale, showing that it had a huge impact on alleviating credit markets, and relief from usury was the title of the paper. So all that is true, but what was probably far more important was building systems so that groups can see what they are doing better. Yeah, because I mean they can talk to each other, and but actually seeing what their credit structures are, what the various women are up to, and that pyramidal structure, the federated structures that are there are all able to see what's going on, and I mean visually see the data. So and therefore and use it as feedback as they improve their functioning, and therefore also get managed better. In other words, an MIS system is central. An actual MIS system that is accurate, that is timely, that is user friendly. I have never seen it done. I'll give you an example. I remember going to CERT many years ago, which had and we were told to go there by the then Joint Secretary of NRLM. Because he said that's the best MI system that he's ever seen in his life, because he developed it. And I took a look at it, and what they were doing was filling up the data in Hyderabad. Yeah, that's not an MIS system. That's a good-looking MIS system. It's not really an MIS system. Yeah. So this kind of thing. There's a lot of window dressing that goes on in this world. Yeah. Now, in the social observatory, we tried our best to fix it. At the end, we went out of business. So, it's hard to do, but that's where scaling up actually takes place. The rest of it is reputation building. Yeah. And I don't think that serves people very well. And at the end, we all should be working towards putting ourselves out of business. Yeah. And that should be the purpose of what all of us do. How do we set up institutional systems? As Purnima was saying, everybody should have access to healthcare in a way that works via a democratic process. Yeah? That is the goal. How do we reach that goal? I think that kind of thinking, I think a lot of people feel it, but that's not how governments often act.
Thank you. We can take Indrajit's question next. I think this is a response to something that Audrey posted earlier. I think probably, Audrey, you could type the answer out for this. I think we'll take one last question from an anonymous attendee, which is, thanks for the great work and sharing your insights from the SLR. What do you suggest for future research? This is a good question to sort of end on. What do you suggest for future research or SLRs on women's SSGs in India? So I don't know, Audrey, Sapna, you think this sort of prodded you towards a sharper research agenda for the future based on what you've observed so far?
Oh, go ahead.
Go for it.
We can both answer. I think it clarified two things. One is we need to, if we are continuing to conduct research on these issues, we as a community need to do it better through mixed methods approaches, through considering groups within a larger ecosystem, and also considering the approaches that groups employ as part of understanding, whether it's community mobilization or what women's priorities are, but really understanding it from the perspective of groups as opposed to the perspective of an outcome that has usually been, dictated by another interest, so to speak. In terms of questions, I think it'll be really important both in programming and research is to consider what a more effective means. For example, if women are of a certain age or if women are primed to hold the system accountable, what are the better ways in which we can do that, work on different health outcomes as well as work in ways that work within an existing health system, for example. Though I do think we should be asking this question of Rajani, for example, to see what from your perspective you'd like to see in terms of evidence.
I think, what I really want to do? I'd really like a program of research where we ask group members what they actually want to talk about and what they actually want to do. I think there's a risk that, as we move through the transitions and people get more interested in NCDs and accountability and urban health and all of these important issues, we do yet more parachuting of health issues on community health workers and groups without actually asking them what they want. And I distinctly remember a couple of months ago being in a nutrition group in an organization that I won't name, where women were sort of whispering, I just want to talk about teenagers and adolescent health because my kids are all grown up and I don't know how to deal with their behavior. And I thought, wow, why didn't we ask women what they wanted to talk about? So this goes back to, building on women's priorities, which I think is a point that Rajani and many of you made earlier. That would be my research agenda, finding out what women want.
Ashwin, if I may just add here very, very briefly, I agree completely with Audrey. Working on women's priorities just enables the environment for them to start working on the other things that we seem to think matter, like NCDs, like mental health, etc. But I think again, and I'm making this point, that we need to have the human resources that can help this facilitation. Unless we build that and take a long-term view that women's groups or any kind of groups or collectives require a strong base of support, both through organizations and individuals, and they can come from the system, they can come from volunteers or whatever. Need to have a strong system of capacity building that helps people or women articulate what their needs are, and then let the government and other policymakers and programmers align their agendas with those priorities. But you need people to do that. It just will not happen by systems, and scaling up without putting this in is a sure recipe for disaster.
Yeah, so my last, sort of last reflection would be, where are the men? And you know, why do we assume that these outcomes, whether they be of reducing poverty, improving food security, improving children's health, that they aren't equally salient for men as well, right? So when we approach it by talking about women's groups rather than, say, community groups, or, you know, supporting communities to achieve their priority outcomes, what have we done as researchers, as funders, as implementers to gender dynamics? And what have we done to sort of leave men on the side who, you know, genuinely care for outcomes? So, you know, there are a few studies. So, you know, we have a study from Bangladesh where couples, men and women, were engaged around gender relations, nutrition, and child health. And, you know, the range of outcomes and the range of impacts on, especially on gender relations, was very powerful. And it's because men, you know, men care as quite a lot about their children and their futures. And so I would love to see a research program that is, you know, that becomes real and sort of really thoughtful about supporting families and, you know, complete entities as they live in their communities on some of these issues that we care so much about. I don't believe women should be bearing the burden for improving their lives, and I don't believe men should feel left out from that endeavor. So I would love to see that, you know, some research on that first, and then we see what happens. Thank you.
Fantastic. I know we're at time, we're 2 minutes over, in fact. I think probably Sapna and Audrey, if you could maybe just type in your email IDs in the chat. Anyone who's had unanswered questions or wants to continue this conversation thread forward post session as well can contact either of you to take forward any pending questions or any burning issues that they have, or any clarifications regarding what you've presented as well. And yeah, as we had mentioned earlier, we'll definitely circulate a link to the recording of this session to everyone who was registered, so everyone can have that handy. And yeah, genuinely wanted to thank all of you for taking time out to be here today, for sharing your thoughts. And this was, I genuinely thought this was a pretty interesting, pretty fruitful discussion. And yeah, thank you all so much for your time. And I don't know, Audrey and Sapna, any closing remarks from your end before we end the session?
I think just to say thank you to all of our participants, and particularly the panelists. You've given us a lot to think about in terms of the review, but that's a small part. And as we move forward in the next stage of this work, we'll be working with implementers and particularly examining what works at scale. So we hope to take a lot of your ideas and integrate it into the next phase of work. So thank you all, and small pitch that the Evidence Consortium will be holding another webinar in a couple of months, focusing on mechanisms in women's groups, where Seema Chandran and Lucia Diaz-Martin, as well as Lou Graham, will present 2 different reviews on mechanisms in women's groups, and we will send out the information. So thank you all.
Thank you so much. Thank you everyone for attending, the panelists, presenters. Thank you so much for your time.
Thank you.